for making me a part of this moderation. And I think the topic is about challenges among uncommon GU cancers. So, first of all, discussing uncommon GU cancers itself is a challenge. And on top of that, we are talking about further challenges. So it's becoming it's definitely a tough call, but I have an excellent team of panelists with me. I hope my colleagues are with me. Vikas, are you there? Vikas Talreja, Bharat.
Yes, sir, I'm here.
Hi,
Good
hi
afternoon,
Bharat.
sir.
Hi Bharat. My friend Satish Rao, he is a pathologist. Bharat is my esteemed medical oncology colleague. Hollis, are you there?
Yes, sir, I'm here.
Yeah, Hollis is also my a very dear medical oncology colleague, and then Satish Rao is my friend
I'm
from
here.
Hyderabad, a very close pathology friend of mine. Satish, are you there?
Yeah, I'm there.
Yes, I believe Gagan Prakash sir also must have joined, and he's a very dear urology colleague of mine. Gagan sir, are you there?
Yeah, hi, good morning. Good morning.
Right. Very good morning to all. So let's begin with this god from a Roman mythology called as Janus. He's basically the god of beginnings, gates, transitions, doorways, passages, and endings. So basically, like you have war and peace, this god will depict two faces, and the month of January is named after Janus. Now, this god Janus has a ubiquitous presence in religious ceremonies throughout the year. In fact, like we invoke Ganesha before starting any ceremony, Janus also is invoked by the Roman people. Let me start with my first case, which is a 58 years old female postmenopausal. This was in 2011. For CA right breast, she underwent surgery, received chemotherapy and post-op RT, and has been on tamoxifen since then because the ER was positive, the PR was positive, the HER2 was 2 plus, and the family refused HER2 by fish. But she went on to get tamoxifen for the plan was to give for 10 years. So 2011 then and now 2021. She was almost nearing the completion of that 10 years of adjuvant tamoxifen. I would like to start with Vikas. In your clinical practice, Vikas, how many postmenopausal breast cancer patients are still being prescribed adjuvant tamoxifen, or have the AIs replaced tamoxifen? Vikas, can you hear me? Bharat, can you answer this question?
Yes, currently in my practice, I would say postmenopausal women nearly 90% are on AI and maybe less than 10% are on tamoxifen.
Right. What about you, Hollis, in your practice?
Yes, sir, most of
Postmenopausal breast cancer
most,
patients, adjuvant
most,
tamoxifen is like buried now?
yeah, I feel so. It is right now. Maybe some risk factors for fractures. Only those patients tamoxifen. Otherwise, most of the patients are on AIs only.
Okay, so this patient actually in 2011 started tamoxifen, and then in July 2021 she had postmenopausal bleeding. A PET-CT scan was done as part of evaluation, showing some nodules in the right breast and in the left breast, which were non-enhancing and non-avid, but also showing a thickness of the endometrium of 25 into 24 into 21 millimeters, SUV of 7.45. Also, right adnexal non-avid cyst was seen, and this thickness of endometrium is of concern. Now, both Bharat and Hollis, can you let me know, do you rate this adverse event of tamoxifen as uncommon or common?
So, Holly, sir, uh, nearly 40 to 50% of all patients on tamoxifen are going to have some uterine pathology. Most I'm seeing is endometrial thickness, but that is in the range of around 4 to 8 millimeters. Although this is 21 millimeters, and so she's currently postmenopausal. So definitely for this lady, it is a major event. But endometrial thickness is what is seen in most of the patients. But progressing to endometrial hyperplasia is quite less.
Right. Bharat, your comments?
I agree with Hollis. postmenopausal women on tamoxifen do get some sort of uterine issues. It's usually an asymptomatic thickening of endometrial thickness goes up. If you're monitoring that serially. Other than that, we intervene only if the patient actually presents intervene. So I think I just will echo Dr. Hollis's thoughts on this. Most of them do have some pathology, but does not mean that we intervene for that.
So this patient for this kind of 25 mm thickness of the endometrium undergoes surgery, and the report comes as grade 1 endometrioid carcinoma, pathological staging T1B, N0, M0, LVI identified, more than one half of the thickness of the myometrium is invaded. So what are your thoughts? What next you think should you do in the treatment? Bharat, you can take that.
So she is basically T1B, N0 grade 1, PT1B grade N0 grade 1,
Yes.
and endometrioid adenocarcinoma. With
tamoxifen is the most likely culprit.
Tamoxifen is the most likely culprit. Cervix is free. Low uterine segment also seems to be free. This patient theoretically can be observed also without any further treatment, adjuvant treatment for endometrial adenocarcinoma. Or some of the patients also undergo at least a vaginal brachytherapy, but on the whole, it is fine to observe also because her pelvic lymph nodes have already been addressed. She's older, either adjuvant RT or observation.
Is Vikas there, or he's not able to join today?
He's just joined in, so you can ask him the question.
Okay. Vikas, hi Vikas. Very good afternoon to you. Anyway, with tamoxifen, the Atlas trial showed that when you use it for 10 years, then the incidence of CA uterus comes to 3.1%. The ATOM trial showed that the risk ratio is around 2.20. The relative risk is 2.20. And you have this meta-analysis showing that the cumulative risk of CA admin increases from 1.5 with 2 years or less than 2 years of tamoxifen to with 5 years of tamoxifen to 3.2% when you give 10 years of tamoxifen. So Vikas, can you let me know that this adverse event of tamoxifen is viewed by you as common or uncommon?
The data shows that yes, giving tamoxifen over a long period of time does have an increased risk of endometrial carcinoma. And in my personal experience also, there has been a few cases of similar way. Usually, that's why we usually switch over from tamoxifen to aromatase inhibitors when we have to extend the therapy for more than 5 years. And I also agree with Dr. Bharat regarding the management of the same patient. The way he told that the brachy is not necessary, the surgery is alone sufficient enough, and stopping tamoxifen furthermore is the best way to go ahead.
So Bharat and Hollis, one word answer from you. Our topic of discussion is challenges among uncommon GU cancer. Tamoxifen causing uterine cancer is an uncommon or a common side effect? Yes or no, or common, uncommon? One word answer from each of you.
So I feel it's an uncommon event. That's less than 1%.
What about you, Bharat?
Uncommon.
Right.
Uncommon.
Tamoxifen, I started with telling about the
uncommon.
Uncommon, yes, with the Janus Roman god who is having a head of 2 faces, and tamoxifen can be labeled as a Janus headed drug because a major side effect of tamoxifen, though uncommon, is after long-term usage you end up getting uterine cancer. On the other hand, it's an efficacious treatment for certain forms of advanced endometrial cancer as well. So with that, we now come to further follow-up after the surgery was done and then further observation was done. 5th of October 2021, 3 months later, she had initially a BCS And then in that area, the right nipple shows erosion. A follow-up was done after a week. It healed well in October 2021, which is like 3 months back. Then again, 2 weeks later, again, erosion of the right nipple. Again, some treatment done, local treatment and some drugs. And November 2021, again, the ulceration subsided. She comes after 14 days again for a review, and now the mammogram shows a right nipple hypoechoic lesion of 18 to 5 millimeters. Color Doppler shows the lesion has vascularity. Otherwise, the other lesions are bilateral, and this has been labeled as neoplastic query papilloma. We go in to get a wide local excision and then finally a right simple mastectomy to find out that the tumor is IDC zero point 0.5 into zero point 0.3 into zero point 0.3 centimeters involving nipple and areola, and there is Paget's disease as well. This LVI, Pagetite involvement nipple, moderate pleomorphism. We check the ER-PR status. It's ER positive, PR negative. The quick score is 6 for ER. HER2 is 2 plus. This time they guess the fish done and the fish comes uh, negative. The key 67 is 28 to 30%. So my questions to each one of you individually is like maybe one answer question. Vikas, what do you think about adjuvant chemotherapy? Yes or no? Bharat, can you take that adjuvant chemotherapy for this patient? 0.5 cm invasive ductal carcinoma, ER positive, PR has become negative, HER2 is negative, 30% key 67. Am I audible?
Bharat sir, yeah, you're not audible.
Bharat, Holis, can you take up that?
Yeah, I'm sorry.
Yeah,
If this patient, it is T1B lesion now, it's 5 millimeters. So, and
it's
PR
okay,
is
Bharat.
negative
Adjuvant
with a
chemo,
high
yes or no? Simple.
67. Very difficult. Yes, some adjuvant chemo, yes.
Okay. Any difference of thoughts, Holis?
No, sir. 4-cycle TC is what I would prefer.
And afterwards, endocrine therapy?
Yes, sir. Endocrine therapy.
Which one? Because she used 10 years of tamoxifen?
I'm comfortable with anastomosis.
Okay. Lastly, what about post-mastectomy RT now? Because RT was done 10 years back. Central tumor, medial tumor involving the nipple, LVI present.
Maybe omit RT, sir. Maybe omit RT
Okay.
because I'm giving adjuvant chemotherapy and endocrine.
Okay, looking at the NCCN guidelines, they say that you can consider if you have central tumors or medial tumors and especially some high risk features like, for instance, LVI, but then that can be considered. So with that, we come to the end of close one. I think we have 20 or 15 minutes more. We'll go to case 2, which is a 59 years old female. And here we would like to involve Gagan Prakash sir also, because we are now going to talk about a female who comes to us with on and off anemia, chronic anemia, but recently requiring blood transfusions, has a right flank pain, which has recently become severe or moderately severe, and also diffuse pelvic pain. An ultrasound abdomen done for this shows a right kidney measure, a shrunken right kidney with dilated pelvic ileal system. There are some cysts there, and below down in the left iliac region you have a 3.5 into 2.5 centimeters lobulated iliac lesion mass, and therefore the right kidney shrunken because of previous insult, and they tell us to get a CT abdomen done. The CTKUB shows a shrunken deformed right kidney. Ureter is dilated, proximal ureter, surrounding soft tissue thickening. The lungs are showing pulmonary metastasis, and there are retrocaval, aortocaval, and left inguinal lymph nodes. So, Gagan Prakash sir, this is what is the final impression of the CTKUB showing deformed right kidney, ureter, proximal dilated, soft tissue thickening suggestive of growth, and some lymph nodes there, multiple lung nodules. In what way would you approach this patient in your clinic? What next?
So, let's start with the basics. I think when reading the CT scan of this patient, one has to make sure that the delayed urogram phrase is included, because that can actually give us a lot of information about this thickening and whether it is involving the lumen or no. And it is often missed, that one would do a CT contrast and end it at the venous phase, whereas waiting for the, and particularly in these kind of kidneys which have compromised function, one has to really wait for the contrast to come into the ureter unless the kidney is a non-functioning one totally. So that's point number one. Point number two is just avoided urine cytology to be seen by an experienced cytopathologist can be an easy test. So with the kind of picture that we have at this age group, an upper tract malignancy is something which one would want to keep in mind if we are looking as the GU system as the primary. The hydronephrosis, of course, could be secondary to a pathology in the pelvis and nothing to do with the urinary tract, and the hydronephrosis essentially just because of an obstructive component. That's one thing. But I think when we are sending the routine investigations, doing a urine cytology and speaking to a cytopathologist, this is what we are suspecting is a good idea. Last couple of years has seen a lot of standardization of this whole urine cytology. And there is a system called the Paris system of reporting for urine cytology, where one is supposed to specifically mention whether this, the whole ambiguity of reporting a urine cytology has come down with this Paris system of reporting. So that's the second thing which I would want to do. Third thing is based on, again, the images and how we feel on discussion with our radiologist is the likely site of the primary. We would want to, we could, straight away go for a tissue diagnosis. Now, the options are targeting either this ureter or the lung metastasis, which is, I don't know whether it is really amenable for an image-guided biopsy based on the size and the site. But, either of these sites or a combination of these sites could be looked for the biopsy. Ureteroscopic biopsies is something which we, do at times, but obviously that requires a little additional procedure, and it also increases the cost because ureteroscopy is a relatively expensive thing, so but that's one of the things which could lead us to the diagnosis.
What happened was that our patient discussed with Gagan Prakash all this, and then Gagan sir patiently explained everything to them. And the patient understood that it could be a neoplastic problem. Unfortunately, he came down to me, and the first thing we as a medical oncology colleague of yours did was to get a PET CT scan done. So this is the PET scan report of 16th August 2021 showing a right kidney upper pole lesion, metabolically active right adrenal gland nodule, multiple lymph nodes there in the para-aortic, the aortocaval, and all those areas, iliac nodes, and multiple lung metastasis. So I didn't have the previous films, and therefore I could not show that to Gagan sir and my team of colleagues here. And so that's the lymph nodal masses there. Those are the iliac nodes, internal iliac, external iliac nodes, and then those pulmonary metastasis. Above to your right, you find that right kidney upper pole mass, and then that dilated proximal ureter or that pelvic ileal system there. So with this, we also found that there was supraclavicular lymph nodes present, left level 4, 5, and supraclavicular nodes with an activity of 5.6, and therefore this node got biopsied. And the biopsy report came as metastatic adenocarcinoma and suggested ISC with all these markers. 5 of them listed their PAX8, CK720, P40, and TTF1. And this is what the report is: metastatic deposits of adenocarcinoma, poorly differentiated in view of mass in kidney, because the PET scan report has been done before the biopsy has been done. Primary in kidney is favored over the mid GI tract. Satish, would you like to help us in understanding this IHC report?
Yeah, basically with that, whatever history you have, if you have provided me during the IHC is being planned, I would say that because of this CK7 positivity CK20 focal positive, it is slightly bending towards urothelial. And a PAX8 will be positive in a renal cell carcinoma. Whatever may be the subtype, usually PAX8 will be positive. So and that's the reason I would still have two differential diagnoses, like just not saying kidney. I would say either it is a renal or I would keep it as urothelial, and further IHC I would have done. And they have done other IHCs like TTF1 to rule out lung, P40 to rule out any squamous differentiation, CDX2 just any GI tract and all those. And more importantly, you see the GATA3. GATA3 is very specific. Actually, you have to keep that in mind. It is not very specific, but it's very classically it comes positive in the breast or a trophoblastic origin or a urothelial origin. So these are the three areas where when the morphology fits in, we usually keep that in as a differential diagnosis when the GATA3 is coming positive.
And Dr. Dattatreya, can I just interrupt you? So this.
Yes, I was going to ask you only, Gagan, what do you feel now with this information given to you?
Yeah. So before that, the whatever was seen on the PET in the kidney,
yes,
is something which was not seen in the CT, and it was only seen on the PET. I mean, that avid area on the upper pole.
I think you're referring to the same thing right here.
Yes.
Yes. So as I told you that maybe they gave that as deformed right kidney and then ureter is dilated. So unfortunately, I could not have the CT films for you. I'm sorry about that.
Okay.
And that's why you have this. In fact, one more thing, Gagan, that right kidney upper pole mass showing so much of activity. Clear cell renal cell carcinomas, usually the primaries are non-avid, right?
Yeah, so I mean, PET is really non-specific for and not very reliable for the primary.
Yeah, I mean, like we have seen that the metastasis may light up, but the primary clear cell RCC usually doesn't light up like the way it's lighting up here.
Yeah.
We discussed, as you rightly said, with our pathologist, and then they came to a conclusion that is possibly non-clear cell renal cell carcinoma in all likelihood. And with
despite
that,
the GATA3 being positive.
Yes. So therefore, with this block, we thought that we'll also get a second opinion. Now, in my time, say when I was doing my DM or just was in practice somewhere back in say 2005, 2010, at that time, second opinions were just in their infancy. But now second opinions have become the norm. So therefore, we send this block again to one more pathologist of repute. And as you can see, the report there is mentioned as possibility of high-grade RCC non-clear cell type is favored. Satish, any quick comments on this?
Yeah, as you say, we are here. Am I audible?
Yes, I can hear you very well.
Yeah. So if you see the CD10 is focal positive, but say P63 is also positive. Because of GATA3, as Dr. Gagan told, what about the urine examination? So I think the urine examination was also should have been asked.
Excellent. I mean, I think Gagan and Satish, both of them spot on. In fact, Gagan sir has requested, we did send the urine for cytology, and that's the 20 ml of urine sample of 9th September, yellowish in color, and the smears are showing mild to moderately atypical urothelial cells. Gagan sir, you were spot on. Satish, what do I do now? Non-clear cell RCC was the diagnosis of the first pathology team, and then the second pathologist also gave that thing, but this report was not known to the first pathology team. What do you think about this?
So you should tell the other pathology team that there are typical urothelial cells. Would you like to be more specific whether you are sure that you can exclude a urothelial or not?
Right.
So you should do further IHCs.
In the meantime, because with this information, what treatment would you prefer? Like non-clear cell RCC metastatic. So it's like IO and IO combination, IO plus VEGF or TKIs, or VEGF or TKI alone, or with this tilt towards query. See, if you can look at the kidney there, it's like very clear right kidney mass in the upper pole, and it's a very shrunken kidney, think renal parenchyma, very thin kidney parenchyma. So would you like to start some treatment, or what do we do? Vikas, Bharat, and then Hollis, quickly if you can answer.
My preference would be to start on a TKI and add IO as per the affordability of the patient. And the the report looks convincing for now, because it looks like a non-clear cell RCC, and the problem with the IO toxicities is the major concern, and the patient is symptomatic, so definitely needs a dual therapy for a better response rate and a faster recovery. So IO plus TKI would be the preference of my choice first.
Bharat and Hollis?
If I can get a very quick answer from the pathologist that it's not a urothelial carcinoma,
Bharat,
I
the
would start
pattern of
a
spread,
TKI,
does it give you some
most
clinical
likely,
clues?
not a
The
TKI.
pattern of spread, does it give you some clinical clues?
Uh, Actually, this sort of spread does look like RCC spread, multiple random nodules in the lung, multiple lymph nodes. Non-clear cell RCCs do exhibit this, but then it's not specific to any histology. So I would start with the existing report, but then I would again further, in spite of, in view of the urine cytology being positive, would ask the pathologist to work up the case further to rule out a urothelial carcinoma specifically.
Excellent answer. Hollis, any additions?
Yeah, one point of yours I actually want to go to comment. Looking at the pattern of spread, liver is involved, nodal disease, lungs are involved. I am going in the favor of a non-clear cell RCC, not in the favor of an IO, and maybe start off with cabozantinib, not with sunitinib, cabozantinib, and then work up for urothelial carcinoma.
Gagan sir, what has been your experience about this kind of pattern of spread and the tumor turning out to be, say, renal pelvis urothelial carcinoma in your practice or experience of the past many years?
Dr. Dattatreya. So, I'm still stuck at more likely diagnosis of a urothelial for the reasons I'll just tell you. So, the scans mention that there is a definite thinning in the ureter with even some periureteric standing and such things which were mentioned. For RCCs to have a ureteric involvement, either the mass is really, really big, which is not the case over here, and the tumor sometimes can really track along the ureter if it's really big, which is not seen over here. So there is something happening in that ureter over there, which I'm not very convinced about. GATA3 being positive unequivocally with this radiological findings, and a cytology which we are not sure of is bending which direction this is going. I would really, really want to assure what we're dealing with. And the thing with urine cytology is that when it is urothelial, they are able to make out very well that it is urothelial. But RCCs can also shed cells in the urine, and RCCs can also have a so-called positive cytology, which may not be a urothelial. And that is why I said this whole nomenclature of calling it positive urothelial cancer cells based on the Paris system makes sense. There's been a concept of using cell blocks on urine being explored for the same thing, because cytology is something which very few people, urine cytology, not every center you would get very experienced cytopathologists, and possibly using urine as a cell block over here could help. But otherwise, I think if we are not sure, and patterns of spread is something which, based on which we and the lines are going to be totally different. So I agree, so if it's a non-clear cell papillary, we've got data that cabozantinib is, better than sunitinib. So that's one direction. And if it turns out to be urothelial, we know that it's a totally different direction for the choice of drugs. So I think we should probably spend a little more time in establishing what we're dealing with. If nothing else, based on the existing information is working out, it might be a good idea to.
Hello.
Yes. So sorry.
The voice is not clear.
Yeah, so I said we should spend probably a little more time in establishing what we are dealing with. And if based on the existing things, we are not certain what it is, I think there is no harm doing a scoping and getting a biopsy directly from the.
It's not clear yet still. So you can switch off the video and
That's speak. Okay. I think we got the message clearly. But in the meantime, what happened was that as Vikas, Bharat, and Hollis clearly mentioned that the patient in front of you is becoming more and more symptomatic clinically, and so some intervention has to be done. And so we started this
Very
patient on
robotic
pembrolizumab
voice.
plus axitinib so that pembro covers both the non-clear cell RCC as well as the urothelial carcinoma. In the meantime, this is what the report came with the cytology report now. Further distinction is not possible in the present ISA workup, but then probably renal pelvic origin urothelial carcinoma. And then further markers were done. Now, this report has now become 15th of September 2021. And further markers, Satish, can you slightly help us in finding out now with further
Yeah.
markers also done by like Vimentin and HMWCK, you came to a
Yeah.
conclusion.
Yes. So basically, CK7 positive, GATA3 positive, PAX8 negative, and Vimentin negative, and then HMWCK positive. So I would expect at least a PAX8 or a Vimentin to be positive in RCC. So which is not there. Although you can have CK7 positivity also in RCC in some subtypes and all those. But I won't expect a GATA3 to be positive in a renal cell carcinoma. And so that's the reason we said it could be a more of a poorly differentiated urothelial carcinoma of renal pelvic origin.
In the meantime, after the first cycle of pembrolizumab and axitinib, the patient's symptoms dramatically improved in 3 weeks' time. And therefore, pembro plus axitinib was continued. And what's gradually now becoming one norm is that to take a third opinion on the pathology report. And so, therefore, it was also sent to another center of repute, and even they gave what Gagan and Satish were pointing out as metastatic urothelial carcinoma. This report is now 27th of September 2021. Having said that, after finishing 4 cycles of pembro plus axitinib, the PET scan report shows the right kidney lesion has decreased. The lymph nodes on both sides of the diagram have gone down significantly in number, size, and activity. The lung nodules have shrunk, and the right adrenal lesion has resolved completely, showing a very good partial metabolic and morphologic response. So to your right is the present scan, which was done recently and showing that the nodes have gone down significantly. The kidney lesion has regressed, and so have all the lymph nodes. Now, Vikas, like pembroaxitinib, we have now two separate reports telling it is urothelial carcinoma renal pelvis, but pembroaxi has worked well. So, fifth cycle onwards, after the PET scan report, which is done in the last week of December 2021, what do I do? Bharat, can you take that? Or Holis?
With this demonstration of response and especially clinical improvement of the patient, irrespective of what we started, we have to continue what is working. I mean, there is no way that we can really change the therapy at this point.
Yeah, Holis, what do you say?
Yes, I agree with sir, because I'm not sure whether it is pembro or whether it is the VEGF TKI that is helping. So pembro would have worked in both, but non-clear cell maybe Nivo AP, but what is working to continue? The challenge comes in the insurance only.
As you can see that even the lung nodules above the recent scans, they have gone down. So everywhere the combination of pembroaxi seems to have worked well. And as Bharat has rightly mentioned, possibly it was because pembrolizumab works against both urothelial and renal cell carcinomas, be it clear cell or non-clear cell. So at the end of it, nothing succeeds like success. So clinically, when you're with the patient, sometimes you take decisions, but afterwards the pathology reports 2 opinions, 3 opinions may come out different. Having said that, if a drug combination or a drug is working in clinic, you tend to continue what's helping the patient. So with that, I come to the last case, the third case for today.
Just a quick, retrospective query. So was she eligible for cisplatin otherwise?
I completely agree, because what about your thoughts? I mean, or Bharat, like, would you now tend to start cisplatin gemcitabine?
We're not starting, but it's worked, so we'll continue this. But I was just wondering if she was with that single or not so well functioning one kidney, was she eligible for cisplatin to start with?
Very good. Excellent question. In fact, I think in practice, all of us make sure that the patient qualifies certain parameters before we put them onto platinum-based chemotherapy, especially when it comes to cisplatin. I think Vikas, Bharat, Holis, all of you agree that we do try to make out a list of 5 points before you put these patients on cisplatin, be it for GU tract or head and neck. Any,
Yes,
any
agreed.
quick comments before the third case starts? Another 5-10 minutes more, and then we
Yes,
are done.
yes, agreed. We will look at the age, performance status, the GFR, the creatinine, and then decide, and the intent of therapy before deciding on platinum. And this patient, at some point of time, if this stops working, platinum may always be an option if she's eligible.
So
Dr. Dattatreya, can I request, in the interest of time, if you can just give the take homes for the third case rather than full discussion, because we are running behind the schedule for 10
just
minutes.
5 minutes, ma'am. We'll take one
Sure.
word answers. 26 years old young female. She comes with a left flank plane for 10 days. CT scan shows, as Gagan sir mentioned, we would look at the excretion from kidney being delayed or not. Shows delayed excretion. A left degestanting is on 29th of October 2021. And these are the scope findings. Ureter narrowing noted, scope could not go beyond that. And the PET-CT scan report afterwards shows a stent in left kidney. Her condition in 1 month from October has worsened a lot. Multiple lymph nodes there. Cervix is bulky, diffuse FDG uptake, and multiple lymph nodes, including involving the iliopsoas and the gluteal muscles. Now, to give the history, she recently had a missed abortion, and she had some right ovary cyst removed, some left ovary cyst removed, and this is now the picture. Diffuse edema, both the low swollen, multiple lymph nodes there. Now those are the iliopsoas muscles involvement, the gluteal muscle being involved, and the lymph node in the inguinal node was very big. We got that biopsied, and the report came as metastatic non-small cell carcinoma. And they advised IHC typing, which showed, Satish, quickly in 10 seconds, can you help us with this IHC report showing metastatic carcinoma, inguinal node, possibly of urothelial origin in a 27 years old female? Very quickly, Satish.
Yeah, see, basically all that history has been given. There's a stricture urethra, but it was not told whether it is intraluminal or extraluminal. The tumor is extraluminal. So I would still, in the preliminary IHC, I would suspect a urothelial origin, definitely.
Perfect.
So, but I would still.
These are the Satish. These are the cervical. This is the PB examination showing the right cervical growth, bulky growth in the anterior wall, and then CA 125 is 1405, CA 7.5, AAP is 199. HCG CA 19-9 are normal. LDH is 967. So all the germ cell tumor markers are high, and so is the CA 125. Now, Vikas, what do you think we should do? Quickly, and then Bharat, and then I'll try to close the case. Her condition was worsening. The report came as CA urothelium. As Gagan sir mentioned, we assessed for starting germ site cisplatin because she was very symptomatic, severe pain, scopies were normal. But Satish, can you help with this, with these findings?
Oh, this is a lymph node, just very fast. It is not looking like a typical urothelial or anything, but a very poorly differentiated carcinoma like of appearance. So without history, I would suspect probably a cervical origin or something like that. And I would do a further IHC to exclude all of the possibilities. And on this, it is came as 57 positive, which can come in cervical origin, and P53 also positive. And with the history of ovarian cysts were removed and all those, the histology was not clear at that time when we were doing the IHCs. So that time, so we include all the markers. Again, the PAC side is negative, and you see the GATA3 was focally positive, and P16 was negative, and all those. So we kind of ruled out a Mullerian origin. We kind of ruled out a cervical origin. We ruled out a squamous cell carcinoma, and then we gave a report of basically because of recent pregnancy, it could be some of a trophoblastic tumor. But we couldn't explain why it is behaving like this, because usually it's not metastatic in origin.
So what's uncommon is at 27 years, you should not think of a urothelial carcinoma, but think of any of these tumors with a history of missed abortion, etc. Gagan sir, quick comment.
Yeah, so that's what I was just about to say, that I'm yet to see, urothelials in 20s unless it is part of an HNPCC or other syndromic cancers.
Completely agree.
So I was uncomfortable with the diagnosis.
Yes, and that's why a second opinion is very important when you get these type of pictures. And the final report of PSTT is again uncommon, but then PSTT do happen. So the patient goes on the EMA-IP regimen. Bharat, what do you say? EMA-IP is okay with PSTT or any other thoughts?
No, I actually use only EMA-IP regime for all gestational trophoblastic neoplasms, irrespective of the histopathology, and definitely for PTSD, I would go with EMA-IP. I hardly use EMACO these days. It's usually, if I'm going for a second line, it is EMA-IP. So I would go for this.
What about you? Like Bharat says, for all GTNs, it's EMA-IP, and EMACO is highly
No.
Okay.
It's not like that. In my experience, I have had difficulties with EMACO where patients have not responded after a single agent.
Right. Excellent. Vikas, any thoughts? Hollis? Well, this patient shows a very good response after 2 cycles of EMA-EP with all the nodes they're going down. I mean, that big nodes have shrunk, and the psoas, etc., the infiltration has gone. The gluteus infiltration has gone, as you can see there. And even the uterus and the cervix has now, you can see the growth there. But what happened was, as I told you now, third opinions are becoming a norm. And that's why this is now the final report of histopathology from, say, Tata Hospital, showing metastatic adenocarcinoma, poorly differentiated, high grade. But EMA-EP has worked very well, 2 cycles. What, Satish, very quick comments about PSTT.
Yeah.
First urothelial, then PSTT, and now it's more like MUO, high grade.
Yeah. So basically, this PSTT can have this.
This is my last slide.
Yeah, this is the CK7 positivity, and but it's negative for P63. Then HPL was also negative, but there can be always an exception. But because of the history of such a strong history of missed abortions and all these things, there's no other possibility there. But I would at least stop at that point of it's probably a rare case of a metastatic PSTT.
Or a malignant PSTT, basically.
Or a malignant PSTT, yeah.
Yes, yes. Any quick thoughts from all the panelists? Vikas, Bharat, Hollis, and then we close this.
Patient has already responded, so just continue with this. And if it's metastatic adenocarcinoma, this is not a curative Indian therapy. So continue till best response and try to keep her on therapy as far as possible.
Does it work really so well for, say, MUO? I mean, like the kind of age, 26 years, 27 years?
Unlikely.
Yes. But then let's see what the future holds, because I think we go in that direction to cure her. Let's see what happens. Bharat, quick comment. Hollis and Vikas.
EMA-EP, maybe the cisplatin component, 80% component might have worked. The challenge would be the number of cycles. We are not sure about the intent now, whether it would be metastatic, the number of cycles, 6, or continue with 4 and then maybe some time maintenance or recurrence. So I'll go up till 6 to 8 cycles of maybe EMA-EP and then take a call.
Perfect. Gagan sir, last comment. Vikas, I think is possibly not there, or Gagan sir, final comment.
No, I would just agree with what everybody said, and the clinical scenario and what has worked is the most important. And I think the cases were the rarest of the rare ones, so really enjoyed those. Yeah.
Fantastic, sir. So Jyoti madam, we discussed diagnostic dilemma, therapeutic enigma, but when, as Gagan sir mentioned, the clinical proforma is in place, you probably won't end up with any sort of professional stigma. Thank you so much, madam. Thanks a lot to all the panelists.
So thank you very much indeed. Great discussion, and in so much unusual situations. So this is actually my dream since long, that in some platform we all can come across and discuss about the situations or astrologies which are not the garden variety. So I'm thankful to all of you for great participation. Thank you, chairpersons, for connecting it so well.